Good morning. Today we'll be discussing two short cases. Uh, as you can see on the picture here, I would like some of you to comment what are your findings upon looking at this patient. Okay, it's an ulcer. Yes. Okay, white edges. Central necrosis. Would you like to comment on the location of the ulcer? How would you go about describing the location of the ulcer? Okay, go ahead. This is a 60-year-old male patient who presented with a gradually progressive ulcerative lesion on the left side of his face below the left orbit for the last 2 years. The patient noticed an ulcer on the left side of the face above the left ala nasi, which was 5 in size at the onset 2 years back. Now, this increased very slowly in size, but for the last 6 months, there was rapid increase in size. Now, apart from this ulcerative lesion, the patient has no other complaints. On examination, there is an irregular ulcer left side of the face below the left orbit. The margin is raised, it is rounded, and there is beaded appearance of the ulcer margin. The floor of the ulcer is covered by a scab. On removing the scab, they found that there is a slight bleeding. The base of the ulcer is indurated, and there were no regional lymph nodes. So, going back to history, what are the points that can help you in making a diagnosis? You could send in your answers now. What are the points that are helpful in getting at a diagnosis? Okay, age, anything to do with the duration, slow growing, okay, and it was initially slow growing, but then it became a rapidly growing ulcer. So if it is just a slow growing ulcer, we would consider it to be a benign ulcer. If it is rapidly growing, it is more in favor of a malignant disease. And on examination, we have points that are important, like the margin is raised, it is rounded, and there is a beaded appearance. So, what would be your diagnosis based upon the history, the small history, and the findings? Anybody, what could be the diagnosis? Okay, now support your diagnosis. Why do you think it is basal cell carcinoma? Why not malignant melanoma? The location, it could be anything. Slow growing is once again a negative point for a malignancy, right? A slow growing ulcer is a negative point for a malignant ulcer. Now, okay, how would you like to confirm your diagnosis? Okay, beaded appearance, true. So how would you like to confirm your diagnosis? Or in other words, what investigation would probably give you a diagnosis? Biopsy, okay. What kind of a biopsy? A true cut biopsy, a wedge biopsy, an edge biopsy, or an FNAC? What kind of a biopsy would you like to do? Biopsy is a very vague term. Okay, he would like to do a wedge biopsy from the edge. Okay, so supposing the biopsy has given you that it is a basal cell carcinoma. So what would you like to do for this patient? Further, what would you like to do for this patient? Now it is on the face. Now what is a characteristic feature of a basal cell carcinoma? In the treatment, these are very sensitive to some form of treatment. Now what is that? Basal cell carcinomas are sensitive to what in the treatment? Anyone? Yeah, radiation, true. But in this present case, would you like to go ahead and give radiation? Yes, they are very radio sensitive. They have a remarkable regression on radiotherapy. But in this patient, would you like to go ahead and offer him radiation, or would you like to do a normal curative surgery? And what is the reason? If you're going to give radiation, why? And if you're not going to give the radiation, why? The answer is in the picture itself, whether you want to give or no. If no, why? Yeah, why should you do a surgery? Why, if it is a radiosensitive ulcer, why would you like to do a surgery? Why not go ahead and give him radiosensitive therapy? Yes, it is because it is close to the eye. Because radiation causes damage to the eye, we should not do this in this case. Okay, and because it is close to the eye and radiotherapy is ruled out, any other form of treatment other than surgery would you like to give to this patient? The patient says, I don't want to get operated on my face, so offer me something else. Patient is conscious, he doesn't want surgery. Chemo, no. More specific, something that can be given locally, directly to the ulcer. In certain cases, it is found to be very effective. Not in all the cases, but in a few cases. A local application of a certain drug, sunscreens and all, to prevent the patient from developing this. Topical imiquimod, anything else? Yes, 5-fluorouracil. In basal cell carcinomas, it has been found that 5-fluorouracil has good chance of treating the disease if it is superficial. Now, if the disease has spread locally or if there is deeper spread, once again, 5-fluorouracil will not be much of a help to the patient. So, supposing 5-fluorouracil was given, it was not effective. You cannot give radiotherapy. Now, then what is the treatment modality at our disposal for this patient? Already one of you has said surgery. Okay. In the surgery, what is the margin that you would like to maintain? The clear margin from the ulcer, 4 to 6 mm wide excision. Yes, correct. Now, is there any role for curettage in basal cell carcinomas? Just, you know, zap it with a diathermy and do a curettage. And can you say to the patient that it is effective? In what kind of basal cell carcinomas? That is the size. Just a curettage would be helpful. You don't need to do a wide excision. In lesions that are less than 1 centimeter, we can offer the patient a curettage diathermy. That would be helpful for them. Okay, you have done the surgery, you have given 4 to 6 of clearance, you have removed it entirely. Now it is on the patient's face, so that is going to leave a huge defect. Cosmetically it is not acceptable to the patient. So then what can you do for this patient after surgery? How is the defect rectified? Okay, skin graft. What kind of a skin graft? No, we have already discussed this in one of my earlier classes. What kind of skin grafts? You would like to do a split skin grafting or a full thickness graft or a distant graft? Now, what kind of a graft would you like to do? Now, this is hardly a 3 to 4 centimeter lesion. It is on the face. So, what kind of a graft would you offer him? Now you can offer the patient a split skin graft. It is the most commonly done thing, or you can go for a distant skin flaps like musculocutaneous flaps. If it is a slightly larger defect, a smaller defects, just a split skin graft would be sufficient. Now, why is it now? Initially, when I asked for a diagnosis, one of you have given me that it is a rodent ulcer. Now, why is it called a rodent ulcer? Why are basal cell carcinomas called as rodent ulcers? Why was the name a rodent ulcer given to it? Spread quickly. Now, what has that to do with a rodent? What does a rodent do? How does it stay? Where does it stay, or how does it build its home? Yeah, it erodes deeper into the tissue, it burrows. So, that is why they are called rodent ulcers. Now, there is a kind of basal cell carcinoma that is called a field fire type of basal cell carcinoma. Now, what is a field fire? Field fire type. Central scabbing and peripheral proliferation. It can also be that one of the margins is a healing type and the other end is a proliferating type. So it appears like as if a field is on fire. One side is normal, the other side is on fire. So this ulcer, like you can say that one end is healthy, healing, and the other end is spreading. Now this patient is having it on his face. Now what are the common areas where you can find a basal cell carcinoma? A few of the areas where you can say that if the lesion is here, it is most likely to be a okay near the eye. Okay, more specifically, you can say face. Inner canthus. Okay. So basically, your basal cell carcinomas, 90% of them occur near the face. More specifically, angle of mouth, the ear lobule, 90% of them. But they can also be found on the nose, the forehead, and the cheek. Uh, can a basal cell carcinoma occur on the peripheries or the trunk? Yes, they can occur, but it is mostly on the face. The peripheries or the trunk is rare. Now, what are the types of basal cell carcinomas that you know of? How would you like to classify them grossly? You could say a two or three. What are the types of basal cell carcinomas grossly? Nodular, yes. Nodulocystic. Before you say nodulocystic, you can also say cystic. Cystic, nodular, and nodulocystic. Plaque-like, pigmented, yes. Navy, anything like sclerosing. Basically, they're like it's nodular, cystic, and pigmented, yes. Sclerosing basal cell carcinomas. Now, you have sent it to your pathologist, you have sent a biopsy. Now, what are the features that you look for in the pathology report? Now, if you want, you will get a question like, what is the histopathology of a basal cell carcinoma? So, what are the features that you see in the slide? A few of them that just give you the confirmatory diagnosis that yes, this is basal cell carcinoma. Basaloid cells, okay. So, basically, it is a basophilic nucleus. Ovoid cells in nests in palisading manner. Mhm. Anything more you would like to add? Something that is absent, that is not found in basal cell carcinoma in histology? There is no presence of prickle cells and epithelial pearls. Prickle cells and epithelial pearls are not present. Now, how does a basal cell carcinoma spread? Is it blood, lymph, or direct spread? How does BCC spread? Yeah, how does it spread even locally? Is it direct spread or lymphatic? A more correct answer would be the spread is direct. Yes, it is a direct spread. Now, basal cell carcinoma can recur. Is there you have treated the patient? Would you like to inform him that see this disease might recur? So you will have to come back to me because if you don't tell that, the patient comes to you and says you have not treated me properly. So can there be a recurrence in basal cell carcinoma? Yes, there is recurrence. Now, what is a turban tumor? What is a turban tumor? Cylindroma. That is, the stroma is arranged in a peculiar cylindrical fashion. So it forms a turban like swelling. These are mostly found where basal cell carcinoma is mostly on the face, the ear lobules, angle of mouth. So where do you find these turban tumors most commonly? They're usually found on the scalp, correct. Ulceration may also occur in these. So to recap, the significant points in favor of your diagnosis in this case were the history. It was a long duration ulcer which had a sudden growth spurt in the last 6 months. The patient has no other significant history or complaints. There was no local lymphatic spread. And on examination, you could see that the ulcer was having a raised, pearly beaded appearance. And they gave a history that upon removing the scab, there was a slight bleeding. And the face, it is present near the left nasi. So it is most probably your basal cell carcinoma. You could confirm your diagnosis by offering a biopsy to the patient. And now, because it is close to the eye, we are not going to offer radiotherapy. However, if it is away from the eye, like if it is present on the angle of mouth or maybe even on the extremities or trunk, it is a very radiosensitive tumor. There is a remarkable regression once we start the treatment. The other option, though widely not successful, but you can offer it to the patient, is a replication of topical 5-fluorouracil. Now, going to the next case. Now, what do you see here? Now, I would like someone to comment on the location of this and also the gross appearance of this. Just looking at it, describe the lesion. No, I have not given you any history. So how can you commit yourself to say that this is a pressure sore? No, same, it cannot, it may not be, it might be a diabetic ulcer. You don't know history. So how can you say it is a diabetic ulcer? It might be a diabetic ulcer, it might be a pressure sore, it might be something else because you don't have any history. So just comment on the gross appearance, just the inspection. Don't jump into giving diagnoses in your exam because at your level, it is not the diagnosis that is important, but rather how you go about arriving at your diagnosis. Yes, it is an ulcer. So anything more you would like to add to an ulcer? There is pigmented skin. Yes, correct. Discharge, we don't know. It's not grossly visible in this picture. It's not so clear. Anything more? Sloughing is there. Yes. There is unhealthy granulation tissue. Okay. Now, instead of one line answers, one of you or maybe some of you could put all of these together into a single line when presenting. Like this is, first of all, you have to comment on the size of the ulcer. None of you have given me a tentative size. The first thing you look at it, you feel it is this size, this shape, present in this area of the body. So how do you go about describing this? It is a solitary ulcer present over the heel of the foot. You don't know if it is left or right from this picture. You could say the surrounding skin is pigmented. So this is a 50-year-old male patient who complains of a pigmented lesion on the right heel for the last 1 year. The pigmentation, it is about 1 centimeter in diameter at the onset 1 year back, and it was slow growing. Now for the last 2 months, it was growing rapidly, and the pigmented area has also spread to involve the whole of the heel and a part of the sole also. And it has darkened in color. So going about this history, now what are your significant points that the patient has given to us to arrive at a diagnosis? From the history, what points would you like to highlight? It is a pigmented lesion, it is dark pigmentation. So because it is pigmentation, you would like to say that it is a melanoma. Any other factor that is in favor of melanoma? Anyone like to comment on the duration? It is present in the sole, okay. The heel pad specifically. What about the duration? That is the first thing the patient tells you, right? He comes to you and he says, I have had this for 1 year. He was not bothered about it. So why has he come to you now? Because for the last 2 months, it has rapidly increased in size. Yes, the patients, they generally come to us only if they find that any lesion is increasing in size suddenly, or if there is pain, or if there is some loss of function for the patient. Otherwise, the patient is not bothered to come to you for the 1 year. So why is he coming now? Because there is rapid growth and it has become darker, and the pigmentation has spread to the heel and other part of the sole. So from your history, these are the significant points: the rapid growth, spread of pigmentation, and darkening of the skin. Now there is ulceration over the swelling for the last 1 month, and the ulcer is also increasing in the size. The patient also complains of having a dull aching pain, and he complains of itching at the local site. So on examination, there is a darkly pigmented nodular solid lesion measuring 7 into 6 centimeters, which is firm in consistency. The floor of the ulcer is covered by necrotic tissue, and the base is indurated but not fixed to the underlying calcaneus, that is the bone. The surrounding pigmentation involves 4 centimeters all around the lesion, and the joint mobility is normal, so there is no loss of function, and there is no lymph node enlargement in the popliteal fossa and the inguinal region. Any lesion that you find on the foot, you have to look for lymph node involvement first in the popliteal region and then in the inguinal region, because these are the areas of lymphatic drainage. So now on examination, you find it is a darkly pigmented lesion that is measuring 7 into 6 centimeters, and on palpation they found that it is firm in consistency, and the floor is covered by necrotic tissue, and the base is indurated but not fixed, and the surrounding pigmentation is about 4 centimeters all around. Now what is your diagnosis and why? Give me a 2 or 3 differential diagnosis, not just a single diagnosis. Whenever possible in your examinations, don't arrive at a single diagnosis. Give 2 or 3 diagnoses based upon the anatomical location or the history or your examination, why it might be a few of the options. So in this case, what could it be? Give me 3 diagnoses. Give me your most probable and 2 others. Pigmented nevus or a nevus. Okay. Anything else? Now, in arriving at a diagnosis in this case, your significant points are rapid growth and a discoloration. So, any rapid growth is almost always going to be a malignancy. So, even in your differential diagnosis, try to think of conditions that match the present description and become malignant. So we have already discussed the basal cell carcinoma. It is possible to occur in the extremities also. So this could be a pigmented basal cell carcinoma. There is pigmentation. It could be. You could also think about Kaposi sarcoma. Yeah, squamous. It could be squamous, or it could also be your malignant melanoma. So now once again, what will you do to diagnose this patient? Give a few investigations that would help in arriving or confirming your diagnosis. So say for now we are thinking that this could be a malignant melanoma or a basal cell carcinoma or a pigmented nevus or squamous cell carcinoma. So what would you like to do that will narrow down your diagnosis? What investigations would you like to order? The same thing, you do not just say a single simple biopsy. What biopsy? From where would you like to take it? Always try to give more specific answers so that you don't force the examiner to ask more questions. If you could give the same answer in a single question, it will fetch you more marks. So what biopsy? Now this appears to be a fairly large. Okay, you want to say you want to do an incisional biopsy. From where? From the central portion, from the margin. So a better way of putting this would be, I would like to advise the patient to get a excisional biopsy from the margins. Any other investigations? Okay, we have already asked for the incisional biopsy, excisional biopsy. What other investigations would you like to ask in this patient? It is present on the heel pad. So, any radiological investigation that you would like to ask to rule out certain things? Directly CT, metastasis. Now, we have already given in the history that the popliteal fossa and the inguinal fossa appear to be normal. There is no lymphatic spread. Yeah, a more basic investigation initially to ask the patient would be an X-ray. So same thing, don't just say an X-ray. Now this is what we found even in your answer sheets. You go about writing CECT. Now, what is a CECT? Which organ would you like to do? Which part of the body would you like to do? Be more specific. X-ray of what? X-ray of the foot. And anyway, you have to do your routine workup investigations because you're going to plan for surgery. Now, what is the treatment? The biopsy has given you that this is malignant melanoma. So you have a confirmatory diagnosis that the patient has malignant melanoma. So, what are the treatment options that you would like to offer? Now, if this is a malignant melanoma, what are the treatment options that we can offer to this patient? It is present on the heel pad. There is no local spread. The popliteal fossa and inguinal fossa are fine. There is no bony involvement. We have checked in an X-ray. Okay, surgical excision. Same thing. What surgical excision? How much margin? Yes, we will offer a surgical excision, but what about the margins? Is it wide local? Yes. Okay, you would like to do a wide local excision with what margin? For basal cell carcinoma, in the previous it was 5 mm, but here when you're dealing with a malignant melanoma, that is an ulcer that is 6 to 7 centimeters across, it is generally 2 centimeters of clear margin that we would like to offer, not just 5 mm, and especially because it is the heel pad. So now it is already a 7 centimeter defect. Now we have given 2 centimeters of clear margin, so making it 9 to 10 centimeters defect. So that is a significant defect on a foot. So after you have removed it, you have given 2 centimeters of margin. What graft would you like to offer to this patient? We are offering a skin graft. In that, what graft would you like to offer to the patient? Would you like to do, okay, full thickness? Why a full thickness? Why not a split skin graft? Whenever you give your answers, be ready to justify them. That will fetch you more marks. Full thickness is a correct. Okay, because it is the sole. This is a dependent area. So the healing is very bad in case of a split skin graft. So we would like to go for a full thickness graft. Okay. Now, does a malignant melanoma involve deeper areas? Is there deeper spread in case of malignant melanoma? Usually, no. Malignant melanomas, they usually don't go deeper. Okay. Now, regarding lymph nodes, now we have told you that the popliteal and inguinal lymph nodes are not involved. So you have done the excision, you have removed 2 centimeters of clear margin. You ask the patient to come for follow-up. Now, once he comes for follow-up, you found out that the patient has lymph nodal involvement. The primary area is fine, it's healing well, patient is happy, but he has lymph node involvement. Then what do? What is the treatment option that you offer to the patient once you found out that there is a lymph nodal involvement in the follow-up? lymphadenectomy. More specifically, now, if the patient comes back and if the patient has lymph node involvement, we could either go for a en bloc lymph node dissection, or we will do a sentinel lymph node biopsy. We'll confirm the involvement of the lymph nodes. Then we go for lymph node dissection. Sometimes, sometimes the patient comes to us, he has the primary lesion, we have diagnosed it to be malignant melanoma. We can also offer a preventive lymph node dissection. It's called an elective lymph node dissection. So because of sometimes the patient, you have to give all the treatment options available to the patient and let them make the decision. You should not make the decision for the patient because it is your preference, or because you like to do it. You cannot force it upon the patient. So we tell the patient that, see, this is a malignant melanoma. There is a chance for it to have a lymph node involvement in the future, even if you remove the primary lesion now. So we can either wait, do a follow-up every 3 months and 6 months. If then you develop a lymph nodal involvement, we'll go about removing that. Or to prevent this, in the direct sitting itself, we can do a preventive lymph node dissection and see how it goes later on. You have to leave the treatment option to the patient. Now, do you want to offer radiotherapy for this malignant melanoma? No, yes, these are not radio sensitive. So there is no role of radiotherapy in malignant melanoma. Surgery is the most curative option available. Now, what are the indications for a elective lymph node dissection? So supposing the malignant melanoma is 1 mm or 0.9 mm, would you still give the option of going for a elective lymph node dissection to the patient? Or if the malignant melanoma is bigger in size, would you then offer him elective lymph node dissection? Say the thickness of the lesion is 6 mm. So if it is less than 1 mm, we are not going to offer. So now in this scenario, supposing the thickness of the lesion is more than 5 mm, would you offer elective lymph node dissection? No, the role of elective lymph node dissection is debatable when the thickness is also more than 4 to 5 mm, because the chance of spread in these patients is very high, and elective lymph node dissection does not prolong their survival time. So in cases where there is higher thickness, the role of elective lymph node dissection is again debatable, and it is not usually offered to the patients. Now, it is usually beneficial if the melanoma is of thickness of 1 to 2 mm, and if there is a chance that you believe that this patient is a bad candidate for a follow-up, that you do the primary surgery and the chances of him coming for a regular follow-up are low, and the thickness is only 1 to 2 mm, it is better to offer an elective lymph node dissection. What is a sentinel lymph node? Usually asked question. It is most commonly asked in your CA breast. What is a sentinel lymph node? You can even be asked a short note on this. It's a very important question. What is a sentinel lymph node? What is its importance? It is the first involved. Okay, that is, it is the first node which receives the lymphatics from the area of importance here. Okay, to know the metastasis. So is there a chance that you do the sentinel lymph node and you found out that sentinel lymph node is not involved, but still there could be other lymph nodes involved? Or would you like to assure the patient that if I do a sentinel lymph node biopsy and if it is negative, you do not have a metastasis? Can you give that assurance to the patient. Yes, no, correct. So you do not have 100% guarantee that the sentinel lymph node is always going to be the first one involved, but there is a very high probability of sentinel lymph node always being the first one involved. So the benefit is more, and we usually offer the patients to do a sentinel lymph node biopsy, but it is not 100%. So what are the other two most common carcinomas where sentinel lymph node biopsy is done? Okay, CA breast, and one more. No, thyroid usually no. This is more in males. One is CA breast, the other one is in males. I think it was discussed in your last class by Dr. Harsha. Carcinoma of penis, yes. Carcinoma of penis and carcinoma of breast are the two common carcinomas where a sentinel lymph node biopsy is very beneficial to the patient, because if there is no involvement of sentinel lymph node, we do not usually go ahead and do lymph node dissection, thereby reducing the time of surgery and also the morbidity for the patient. Now once you go and handle the lymph nodes, usually patients will have long-term complications on that area. Now supposing this patient has a lymph node that is palpable, what investigation would you like to do before going ahead and dissecting it? Any investigation? FNAC, yes, but in this patients, if it is grossly palpable and clinically you feel that it is involved, you can directly go ahead and do a dissection. Only if you are having a vague idea that it might be a lymph nodal involvement, or if you have a doubt that there is a lymph nodal involvement, we can go ahead and do a FNAC. So once again, this is a 50-year-old patient, history of 1 year, with rapid growth in the last 2 months. So that is one important factor. There is pigmentation, that is also an important factor, and there is rapid growth of the ulcer for the past 1 month, and patient complains of dull aching pain. And on examination, it is darkly pigmented, present on the heel pad 7 to 6 centimeters. It is covered by a necrotic tissue, and there is no lymph node involvement. So we arrived at a tentative diagnosis that it could be a malignant melanoma or a pigmented basal cell carcinoma. So we have asked the patient to get a excisional biopsy from the margin of the ulcer, and it was found to be malignant melanoma. Now, the best treatment modality for a malignant melanoma is to do a wide surgical excision with 2 centimeters of margin, and the defect is covered by not split skin grafting but full thickness grafting, because it is present on the heel pad. And heel pads, when given split skin grafting, you can do it. There is nothing stopping you from doing it. Sometimes it might be successful, but usually you end up in failure. So better to directly go ahead and offer a full thickness grafting. Now, these are not radiosensitive like the basal cell carcinomas, so we do not offer that. And regarding the lymph nodes, if they are grossly palpable, we do not go for FNAC. We can directly go ahead for en bloc dissection. Now, once again, the dilemma here is whether you offer to do an elective lymph node dissection or you wait and follow up. So the best way to decide that is, if it is 1 to 2 mm thick, that is not more than 4, or if the size is small, and if you feel the patient might not come back for a follow up, it is better to directly go ahead and do a en bloc elective lymph node dissection. But if it is not fitting into these criteria, if the patient could be a regular follow-up candidate, if the thickness is more than 4 mm, then we directly do not offer a lymph node dissection. We go ahead and do the wide local excision with 2 centimeters margin, and we ask the patient to come for follow-up. So any doubts? This is usually not kept in the exam, but if it is, it is easy to diagnose this. You see that the ulcer is pigmented and there is history of fast growth, and don't usually give a confirmatory diagnosis. That is not possible to arrive clinically. So you could say to the examiner that I would like to give a probable diagnosis, sir. It is most likely to be this, but I would also like to keep in mind the following diagnosis. So then you can guide the examiner to ask you questions that how would you like to confirm your diagnosis. Now you would already know that you would like to do a biopsy or an FNAC or a true cut or a wedge biopsy. You can guide the examiner to ask you questions where you feel you are more strong. Once you give a confirmatory diagnosis, the discussion is going to be on that particular disease, or the examiner might feel that you have already been given the answer and that you have cheated in the exam. So always justify your answers. Like whenever you say something, you should have a reason for saying that. So why is that? So if you say I want to do a excisional biopsy, so have a reason to do that. Why not directly go ahead and do a complete excision? Why not offer that to the patient? Why would you like to do so? If I'm an examiner, I would like to ask you, why would you like to do a biopsy when you can directly remove it and send it to the histopathology? So then you could justify your answer saying, so if I remove it and it turns out to be malignant, then the margin clearance become a problem, so we will have to redo the surgery. So doing a biopsy is helpful in that it will help us in arriving at a diagnosis. Then we can make a decision that if it is radiosensitive, surgery can be avoided altogether. So like this, you should always have a justification for your answer. Any questions? Usually history is also not required for your short cases. You will only be asked to do inspection, palpation findings. However, you could ask the patient for a small history because it will help you in arriving at your diagnosis, but it is not usually required to present it to the examiner. Okay then, thank you.